DVT is going to be a little bit different from us in emergency medicine versus you guys in the ICU. Because in emergency medicine, people are typically ambulatory and are coming in because their leg hurts and they want to know if they have a DVT. And so we are going to be performing a point of care ultrasound, which we will use instead in lieu of a radiology ultrasound, and we can discharge people home based on our ultrasound of a negative point of care ultrasound. In the ICU, you guys are going to be using it differently. You guys aren't usually like seeing someone for an isolated swollen extremity and discharging them home after it's negative. Typically, you guys are going to be in a more emergent situation. You're going to want to know. I mean, sometimes it's just like, does this person have a DVT? But the thing is, most of the time you're going to order a radiology exam. It's not a critical diagnosis until they come in with like what you suspect to either a submassive or massive PE, or someone in some form of shock, and you want to know, is pulmonary embolism a cause of their shock? And so we are going to try to do a quick DVT ultrasound, because if you find a DVT in someone with a shock state, it dramatically increases your probability that their shock is from an obstructive cause or from a massive pulmonary embolus. So we'll start off by talking about the anatomy of the leg and where you put the probe, normal versus pathologic ultrasound image, and the evidence behind doing the DVT scans. Okay. So you'll hear a couple different point of care protocols. Some people call it 2-point compression or 3-point compression, and then you'll hear the radiologists do the whole leg compression. Generally what we do in the emergency department is the 3-point compression here. And this is going to be the 3 points of compression are going to be at the groin of the common femoral vein. Then we're going to move down to the superficial femoral vein, or what we just call the femoral vein. People have dropped the superficial off of it for reasons that are confusing, because it is a deep vein. And so when you call it superficial femoral vein, I guess historically some people have not anticoagulated that and realized, have come back with bad outcomes because they didn't anticoagulate a DVT. So this superficial has dropped off a lot of times, and you'll just see it called the femoral vein. And then finally, the popliteal vein. So CFV, femoral vein, popliteal vein are the 3 points that we're going to do the compression at. And from those 3 points, we usually can adequately tell if someone has a deep vein thrombosis. CAF DVTs are debatable whether they're clinically important, at least from the emergency department standpoint, and whether you should anticoagulate them or not. So we're not going to talk about CAF vein DVTs here. So 2-point would be just the common femoral and popliteal. This has pretty good sensitivity, but if you want to really increase your sensitivity, you just add that third spot. And since you have the ultrasound machine in your hand, you're already doing the exam, going down a couple inches on the leg is not usually a big deal. It adds like 5 seconds to your exam. So why not increase your sensitivity with one more area of the leg? I will say it's pretty uncommon to have an isolated femoral vein DVT, at least in the emergency department. The more ill or the more non-ambulatory you are, or the opposite to just sedentary and immobilized, the more likely you are to get a isolated superficial femoral vein thrombosis, but it's pretty uncommon to have one just here. And then finally, whole leg. What radiology does is the whole leg, including usually the calf. So what do we need to do in order to diagnose a DVT? Well, you're going to use the linear probe, so it gives you a high resolution view, and you're going to do a compression of each area. And by compression of the vein, you'll be able to, if you can fully compress a vein, you are inferring from that full compression that there's no intraluminal thrombus at that point that would block you from doing a compression, and therefore you don't have a DVT. So you can sometimes visualize the clot, but that's not good enough. You need to be able to fully compress each one of those 3 areas that we talked about here. You'll notice as this compression goes on, they're fully compressing the vein. This is the common femoral vein. The arteries next to it, there's no compression here. The vein should always compress before the arteries, and this is no DVT. I'm looking at this now, and they're actually not doing now that I look at this, they're not doing a full compression here. They're leaving it a little bit off, and this drives me nuts when I do. So I'm the director of quality assurance, so I'm going to change this for next year's lecture. I thought I caught all the bad stuff that was left behind, but this needs to be pressed on a little bit harder to do. The intima of the vein should be touching the intima of the vein back here. So we'll see a better one here. The number one cause of people getting a false negative DVT scan, or at least for me to send them an email, is to not get a compression high enough in the leg. People like don't want to get all up in there. So especially in ambulatory patients that have underwear on, people don't go high enough. You need to get all up in there. You should see pubic hair to do this compression. You should be at the inguinal ligament. They should not have any pants on. I mean, if their underwear's on, if it's like loose fitting underwear and you can curl it up, that's fine. But really, you need to get up in there. You should only see one artery, one vein, as demonstrated here. And when you do a compression, I mean, this is, a graphical model where this is really the intima. You should see the intima being compressed right here. So both sides should touch it. And they're doing it so hard, they're getting some arterial compression here. So this is a sign that there's no clot in the common femoral vein. As you move down the leg, both of the arteries and veins bifurcate. And so you get the superficial branches of both, and the deep branches. Again, a lot of times the superficial is left off, so you could just call it the femoral vein, and then the deep femoral vein, deep femoral vein. So there's the arteries, the superficial collection, the deep collection, and then you have your arteries, and then you have your veins. And so you'll see 4 structures. When you do the compression, the arteries should be the only ones left over. The 2 veins should be collapsed. We're not really looking at the deep femoral vein. We're just looking at the superficial femoral vein, or the femoral vein right here. This is the one that people are concerned about. And then finally, when we drop down to the popliteal fossa, you're going to look at the popliteal artery and popliteal vein. There's a saying that we have that the vein is on top and the pop. People like that because it's sometimes hard to remember which one's which, especially if they're about the same size, and especially if there's a clot in them and one's compressing and one's not. And you're like, wait, which one? Is this an arterial clot? Is this a venous clot? So the vein is on top and the pop. And now some people will get mad because it's not technically on top. It's closest to your probe. It's on top of the screen, but technically it's the most posterior in the leg. So people have asked me that. It is on top of the screen in the pop. That doesn't sound as good, as nice. So that's the popliteal compression. And so let's see. Previously, when we didn't save a lot of videos on the machine, we used to use just images. This is what they still do in radiology. They'll get an image like this of the common femoral vein, and they'll do a compression side by side or split screen, and they'll show the compression on one side, non-compression on the other side. We typically just save videos now instead of just doing still images. It's easier to interpret. And bandwidth issues are not a big deal, like back in the day when people didn't want to store a lot of data on the servers. And now, you can store a terabyte for probably a couple pennies. I don't know how much it costs, but it's cheap. And so we'll just save a video with the compression, but you'll see this is how radiologists or sonographers send it to the radiologist. Superficial vein, or again, femoral vein. So here you can tell that here's the vein. And there's always, like, when I look at pictures, it's a little hard to interpret. You're like, well, is that complete compression if it's just a still image? But that's why I like video. You really can see it nicely. If you scan with or if you're with the radiologist when they do this, it's like almost, it's crazy how much the sonographer makes or breaks this scan. The radiologists freely admit, they're like, the sonographer kind of does everything here, and they just scan through the images and they're like, yeah, no DVT, or whatever the sonographer says, because it's so hard to override what the interpretation of the sonographer when they're doing DVT scans, that I feel like the sonographer should make the radiology money in this scan, but they don't. So sonographer makes or breaks it. So you'll look at some of these images and you'll be like, I don't know, is that full compression when you order a comprehensive? But then at the end of it, when you look at the last slide of a comprehensive ultrasound, it always says the sonographer interpretation. And so that's pretty much never overruled in DVT scans. All right. So what does the clot look like? Well, it depends on the age of the clot. So sometimes there'll be echogenic structures in the vein that doesn't compress, but sometimes it will be anechoic. So if you see one of these structures, you'll know that, I mean, for one, that there's a clot. but this is a pretty old clot. Now, I don't mean to say that it is like not important, but it has been there for a while. An echogenic clot like this, and you can even see it extending to the greater saphenous vein as it enters right here. So this is a DVT. We'd still call it, you know, an acute DVT, but it's just been there for a little bit longer. Whereas, is this project well? Do you mind turn on the lights per? Yeah. You guys see that here? So there's an echogenic clot. The right side of the screen, remember how the echo text show it, is this is the compression side. So there should be nothing here. Ooh, it's pretty dark. So there should be a complete compression of this, but you still see it exactly the same as the side of the screen. So this is how they show that there's a DVT. All right. So here's compression. Here's a DVT. So if you saw someone with some form of shock and you did not know the shocks, the etiology of the shock state, there is a protocol we're going to do. I'm going to teach you guys later. Some people, it's called the RUSH protocol. Granted, it's not directly involved. The DVT scan is not directly involved, but some people will add this on to the hypotensive or RUSH protocol to try and increase their specificity for obstructive shock. And so if you are suspecting a PE and you're wondering about thrombolytics and you don't want to push thrombolytics because of whatever reason, without some form of confirmation or at least a higher probability of getting the right diagnosis, usually it's impossible to send someone to the CT scanner. I don't know how it is up there, but usually we don't like to send hypotensive patients to the CT scanner. So you can do this rapidly at the bedside. You're still usually going to do a cardiac exam as well. But if you see a dilated RV with a DVT in the leg, almost certainly this is the cause of their shock. So here's another compression. Notice the echogenic clot. Here's another one. DVT right here. Another one right here. So it doesn't have to be fully occlusive. So here, you might be able to see there's something echogenic in there, and with complete compression, or with, I shouldn't say complete compression, but with compression, there is still a clot here. Looks like an arterial clot over here, but there is a non-full, they're not fully compressing the vein over here with a lot of pressure. So there is still a DVT over here. We don't really make a difference. There's no clinical difference for us between an occlusive and non-occlusive DVT. This one's a little bit harder to see, but you can see there's an echogenic structure right here that doesn't allow complete compression of the vein. And then let's see. All right. So this is a fresh clot. This one's a little bit right. Let's see. Hold on. Right there, you can barely see it. So that's a pretty fresh clot. This is a moderately old clot right here. And then this one is like echogenic is the other structure. This is an old clot. Again, it doesn't mean that it's not important. It's just, it's been there a while. So you can tell when you do compression that this structure is stented open by some intraluminal thrombus. So that is the DVT. And I'm going to just flip through the end of these slides here because I don't want to take up too much time. I want to keep us on track here. Another popliteal, here's a popliteal vein thrombus. I'm going to take this video off for the next lecture because next time I do this lecture, because that is a weird, because the vein should be, this is an artery right here, and this looks like an echogenic clot here. I don't know why it's flipped, if there's some anatomic variation, but it looks like, this looks like the artery with the thicker intima right there. Anyways, the accuracy of a DVT ultrasound, I did not know this was up there the whole time. I apologize. Is pretty good. 97% sensitivity and specificity, 96 to 97% sensitivity and specificity for emergency physician performed ultrasonography. So It's pretty good. We use it in the emergency department to discharge people. If we're still concerned after a negative ultrasound, you could order a comprehensive ultrasound in the ED, but usually what we do is discharge people home and tell them if your symptoms still persist after 1 week to get another one. But that will increase doing serial ultrasounds will increase your specificity. Excuse me, your sensitivity for the diagnosis. So that's what we do in the emergency department. So compression is what you need to do. It's not specifically visualization. Visualization of the clot helps, but compression is where the money's at. You don't need to do any of the flows that they do in the ultrasound, the sonographers do, where they put color flow on and look at Doppler. Don't do that. Just do compression, but you need to do it at 3 points, all the way from the inguinal ligament to the popliteal vein. Color flow isn't needed, and the more ultrasounds you do, the better you get at, just like everything in ultrasound. So